Welcome, everyone, to another episode of hashtag CRA Arthritis. Today, we're very lucky to have with us Dr. Andrea Fava. He's a faculty member of the Johns Hopkins Lupus Center, where he's involved in the care of patients with different types of lupus, including SLE and lupus nephritis. His research is focused on lupus nephritis, including the discovery of new or treatable mechanisms and non-invasive biomarkers of lupus nephritis. Dr. Fava, welcome to our show.
Thank you. It's a pleasure being here. Thank you for inviting me.
To start, maybe we can just run through some definitions for our audience who may be familiar with the more common or prevalent type of arthritis, SLE, maybe less so lupus nephritis. Can you explain the two different types?
Yeah, SLE stands for systemic lupus erythematosus. It is the systemic form of lupus and usually means that there are multiple organs involved and multiple antibodies. Lupus can, well, usually when we say lupus, we just indicate SLE, but SLE can affect multiple organs, and in some situations, things may be what we consider milder, which means that are not organ threatening. Things that could be joint pain or sometimes rashes, and we understand that rashes can be quite severe, but there are organ-threatening manifestations that could affect internal organs, and they can, have a higher risk of mortality or permanent damage. And of those severe manifestations, the involvement of the kidneys, that is called lupus nephritis, is the most common type. Some patients may have just lupus nephritis and no other organ involvement, but oftentimes lupus nephritis is part of SLE because usually there are also other parts of the body that are being involved.
Now, your research looks at something called liquid biopsy that's a means to help us better understand lupus nephritis. For patients, what does that mean and how does it work and how is it different from, let's say, a kidney biopsy that's more commonly and currently used?
Yeah, so lupus nephritis most of the time is silent. What I mean by this is that more than 50% of people have no symptoms whatsoever at the time of onset and diagnosis. So, what we do in clinical practice is that when you come to clinic, we check for an abnormal amount of protein in the urine. And if it's high, in order to figure out if there is indeed inflammation in the kidney, we need to do a kidney biopsy, which is basically taking a small piece of kidney with the needle, look under the microscope to see if there is inflammation or damage or something else. If there is inflammation, then and if that inflammation looks like lupus nephritis, then we know how to treat. Now, the biopsy is absolutely critical to tell us how exactly to treat. Now, a liquid biopsy is trying to achieve the same, to get the same information without having to do a procedure, without having to stuck a needle in the back to take a piece of kidney. A liquid biopsy is using a urine sample. And you can imagine how urine being downstream of both kidneys can capture and can collect the byproducts of inflammation in the kidney, and we can measure them from the outside non-invasively. And what we're trying to do is to use that information to tell us if there is inflammation or not in the kidney.
That's really an exciting development in a less invasive way, as you're describing for patients to undergo testing. Now, your study identified specific inflammatory signals in the urine linked to disease severity and treatment response. What does this tell us about how lupus nephritis behaves in the body?
We know that lupus nephritis is complex, and we understand only a part of it. We even under the microscope, there's not just one type of lupus nephritis. We actually we have six classes, six different types of lupus
Well,
nephritis, and even among those, there's a lot of variability among other features. So we always read the biopsy to tell us what's going on. The what we found in the urine is giving us hints about what is a type of inflammation that is active in certain patients and not others. And we found, as you can imagine, inflammation is not one thing, it's many things. And so
Hmm.
we could identify a lot of them. So to give in broad strokes, what we found is that we found signals that indicate inflammation, and we captured that there are certain types of cells, such as the neutrophils or the interferon. These are like important inflammatory pathways that we hope to target with treatment. But we could also find um, proteins in the urine that can tell us that the tissue itself is being injured, remodeled, or there is a scarring process ongoing. So when we when we look at these biopsies, we want to know if there is treatable inflammation, and we want to know how much damage there is, because they are both important variables to know. We obviously, our goal is to prevent damage, and we want to be able to see if there is ongoing damage. Also, if we know the amount of damage, it can help us making a prognosis and understanding, if what is the risk of future permanent reduction in kidney function. And so we are identifying at the same time what are some of the pathways that are implicated in causing the inflammation. So hopefully that can make us smarter in the way we select treatment. And also we can identify what are the pathways and the processes that are implicated in causing scar tissue, which is what we want to prevent.
So you talk about helping with the treatment selection, and our audience, when we report from the annual scientific meeting, have seen and heard many of our reports that are focused around this concept of personalized treatment approaches. So I'm wondering, looking ahead, how could this type of testing that you're helping lead and pioneer help doctors and specialists maybe personalize treatment and improve outcomes for people living with a real serious disease like lupus nephritis?
So what we wished at the beginning was to have an assay that could tell us before making the first decision, it could tell us which treatment to pick. Based on the studies that we have, we were not able to do so. We have new studies coming up that might be helpful, but we don't know yet. However, after the initial depression and not being able to find these results that we wanted, we started thinking. And we said, well, listen, there are patients that after a year of treatment, they do respond. And we couldn't predict it at baseline, but if they responded, something must have happened in the kidney in response to treatment. And what we did, we looked over time at the changes in the proteins in the urine. Because I haven't said this, but the beauty and what's practical about a liquid biopsy is that it's just a urine sample. You can just take it anytime you want. Of course, I would love to have information from a kidney biopsy every few months, but I'm not going to ask anybody to give me a piece of kidney every 3 months. And so what we found is that already after 3 months of treatment, we could predict who was going to be a responder at 1 year in a way that was superior to what we have available right now in clinical practice, things like proteinuria. And so the way that this can impact clinical practice is that if I can start with, the best treatment I have, and then already after 3 months, I can tell if somebody is responding or not having to wait a long time. Because right now, what we do and what patients with lupus nephritis know is that in clinic, we follow proteinuria, which is the amount of protein in the urine. And if it goes down, we are happy. If it doesn't go down, we worry. But there's a big problem there. Because in studies in which we have obtained a second kidney biopsy after 6 months or a year, we found that a low proteinuria doesn't always mean low inflammation. And a lot of patients that have complete resolution of the inflammation in the kidney continue to have high proteinuria. So proteinuria is fooling us.
Hmm.
And the majority of the irreversible damage in the kidney happens in the first 6 months.
Hmm.
So if we wait 6 months or a year to realize that the treatment was wrong, we may have lost our window of opportunity. So what we are working on right now in the validation studies that we are running is, can we confirm that we could use this assay, this test at 3 months already to tell us if we made a good decision, and if not, let's not waste time. Let's escalate treatment so we could prevent damage. And we are even trying to see if we could do that even before the third month.
Wow, it's fantastic. Congratulations on the science. I mean, it's truly exciting, and I think offers hope for people living with lupus nephritis. And we really look forward to seeing how you advance and look forward to speaking with you again. Dr. Fava, thank you for joining us.
Thank you. It was a pleasure.
And thanks to our audience. And we look forward to seeing you on another episode of hashtag CRA Arthritis. Bye for now.